thalamus. Okay? We get to the area that it's got to do, the thalamus determines which area to send it to. Next thing we got to deal with, we have to deal with getting the response. All right? Oh, because I went backwards. I was going to say, whoa. So this is an example showing how we could have the transmission of a signal, where we could actually be picking up something, all right? Because here they're showing there's a receptor somewhere in the body, all right? I used the representation of the pressure from the chair, okay? So that makes its way to the spinal cord. Note that that sensory information, okay, because you were asking earlier, all right? Now, what do you note about my sensory information and where it enters?
Zigzagging.
But you were asking, did it enter on the gray matter of the posterior or anterior? So what do you note about that sensory information coming in?
To the gray matter.
It went to my gray matter on which side?
Posterior.
Posterior. Does everybody see that? Okay, so now we meet our neuron. Now the zigzag. What way did we say information could go? We could decussate, we could contralateral, we could ipsilateral. And what do you kind of see the little zigzag doing? On this picture, we're seeing it. Let's pretend like it's facing this way, okay? So we're seeing information come in on my left side, and what did we see it do?
Crossover.
Decussate. I know, yeah, that's a cool term. You know, you think about it. All right, it's like you. Angus. Okay, so we see it come in, move over, and travel up. And we get to the region of my thalamus. Thalamus then determines where does it go. In this case, all right, it took it to my the cortex of my cerebrum, because that's where some of your intentional movement is going to come from, okay? And then, now that I've sent the information up, it's gotten to the right area of the brain, all right? Now, I got to worry about stuff coming down for the effect, okay? So I've had that ascending track. I've sent it to the area of the brain where it needs to go. Now, it needs to come back down so that I can get the effect. Shift in my chair, sit up a little straighter, you know, whatever the case might be, all right? Descending tracks are my motor. Because anytime you hear motor, all right, I want you guys to associate that with muscle, okay? Because skeletal muscle, because a motor makes something move, right? We got the motors in our cars, and they make the cars move, all right? So motor means I'm going to get an effect. Something's going to happen. These have two neurons. So, we simply say there is an upper and a lower. So now, We had it originate in the cortex, okay, of my cerebrum, the cerebral cortex. It traveled to the level of the spinal cord that needs to carry out the effect. So if we're thinking about the pressure of the chair on our lower body, it's going to send it to the level of the spinal cord that will help us get that spinal nerve to go to the muscle that makes us shift in the chair.
When I was asking that question earlier, it was because at the beginning of class you mentioned that some of the processing happens in your brain, some of the processing happens directly in your spinal cord.
Where you going?
Okay.
Show me your hand.
Sorry.
I'll let her start teaching. Let's sit down. I'm going to show you. No, but that's true, because what we will begin to notice is some of our movement is very intentional, okay? Taking a note, opening or closing a book, picking up a purse, moving. Some of it is very intentional. And that means we have actually thought about that, i.e. cerebrum. Some stuff that happens, some of the stimuli that might require a response is not always cerebral, meaning we've thought about it. What could happen in the body for a movement to occur that we haven't thought about?
Digestion.
Hmm?
Digestion.
Definitely. Can you think of something that might occur with skeletal muscle?
A reflex.
Reflex. Reflex. So, at this point, remember, all of this information is dealing with what will happen with skeletal muscle. In a bigger picture that I'm hoping you guys are kind of making an association with is patients who may have decreased movement or response or passing of information because of injury. Whether that's going to be spinal cord injury or nerve injury. I'm hoping you're kind of putting it into the bigger picture, that you're now learning why that may be the case.
Mm-hmm.
Can you give me an example of a patient that might still be pretty good, mobility, but there could still be some damage?
I have a patient who's like 58. He got in a car accident when he was 18, and it paralyzed him from the neck down. So he has to use a fully catheter, and he always has reoccurring bladder issues because he can't control it. But I mean, I guess over time, him doing a little bit of therapy and stuff, he has some function, but he still really can't control it.
Now, what you're going to find in that case right there, now, is he fully quadriplegic? In other words, upper and lower? Okay. And then, of course, you mentioned his viscera, because you mentioned the Foley and the urine, that sort of thing. Because you're going to find that in the structure that we have, now, I keep trying to point out, right now we're looking at it as skeletal muscle, but we had that lateral horn on the gray matter. And what did I say that was associated with?
The ganglia. Ethan coming in.
Organs.
Our autonomic nervous system, our viscera. So he's at the patient, the example that's been given, that patient is actually not able to control the bladder functions because of because that damage occurred and it affected all the way down. That's the reason.
And that's a spinal injury that is affecting the nerves.
Because,
I think it's like on T3, like all the way down.
wow. Okay, yeah. Because that bladder control would be from lower regions of this spinal cord. And if it's been severed, that information can't pass, which is why he can't have any control over his bladder.
So the nerves are still okay, they just can't communicate with the spinal cord, so.
Well, now, once that initial severing has occurred, it does take not a lot, okay? It takes just a small amount of time, but then those nerves begin to die.
Die off because there's no connection.
Yeah.
Okay.
Mm-hmm.
But can they possibly like reconnect or reform some kind of way or something? Because like he's like he tries to do therapy, like they try to help him or whatever, and even though he has the phobia and stuff, like he'll tell you like he thinks it's full or he thinks you need to change it and stuff like that.
There could be some peripheral
Okay.
nerve feeling that's there.
And like,
Yeah.
My boss always says in his mind.
Yeah.
Yeah.
Yeah. And actually, you know what? I can actually give a really good explanation on that. Okay? All right. So, for and I'll use, because this is the perfect example. My hand surgery. All right? So, the first time when I had this hand done, like back in August, I did it while I was awake. You know, they only did the local, okay, because I wanted to see what they were doing. However, they hit a nerve putting in the local, and my hand will never be right, okay? So when it came time to do this hand, everybody, you know, they were like, well, why are you using the same doctor? Well, think about it. They know they did wrong about it, okay? So you got, dude, you know he's watching what he's doing on this one. So, this time I chose to go ahead, do it in the hospital with real anesthesiologists, okay? And they do the block, okay? The nerve block. So, when the anesthesiologist came in to do the nerve block, I was in this position right here, because they have to, like, they do ultrasound and find the nerve, and then they're using the needle to go in and press on the nerves to make sure they know which ones to exactly inject that stuff into. Weirdest thing ever, okay? Because when they finally administered the nerve deadening or whatever it was, you know, you're just kind of like, and they leave and they're like all done, and you're still thinking that your hand, your arm is right here. And so, you know, I'm just laying there waiting for the doctor to come in, and I'm thinking the whole time, my arm's right here, okay? I look over,
Oh my God.
and it was over here hanging off the bed, okay? And I'm going, that's not where my arm is. My arm's right here. That was the last time the brain picked it up. So even when they took me back in the operating room, and they're doing all this stuff, you know, getting my arm, laying my arm out, and doing, I'm still feeling my arm right here. Talk about weird. Oh, it was like the weirdest thing ever. And then, you know, it stays deadened for about 16 to 18 hours, okay? So you're like in the sling and all this sort of stuff. And I come home, and you have to really support it, because, I mean, it's dead weight, totally dead